Greetings, everyone. This is Eric Glazer, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to inform you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations. Our goal is to identify as many bright spots as possible so that you could determine if the ideas shared during this very episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. Now, if you are watching or listening to this for the first time and you have not subscribed to the Bright Spots in Healthcare podcast, I encourage you to do so right now. All of our episodes feature leaders from the payer and provider community and some of the most innovative solution providers out there with great ideas. You don't have to listen to me. You listen to all of your peers. Go to your favorite podcast app, type in Bright Spots in Healthcare, click on subscribe, and you'll get all those great episodes downloaded to us. I think we're actually averaging like 4.8 stars on the Apple podcast app. So this is good stuff. We have great guests, and they're going to provide you a lot of value, just like the all-star panel you see in front of you today. And our topic is super important and super topical: how innovators are addressing GLP-1s, obesity, and MSK. So we're excited to get into this. If you want to learn a little bit more about our panelists, we've provided in the podcast description a link to their bios. You'll also get, if you're watching live via Zoom, a link that our producer Sherry Keels is going to post in there for you, and you can get a little bit of a rundown of the incredible experience and expertise you're about to benefit from. But we are going to bypass formal intros to save us lots of time. Our partner for today's episode is Vori Health. If you haven't heard of Vori Health, they're an exceptionally innovative and cool company. They're a specialty medical practice delivering a virtual first musculoskeletal solution to help members get back to their lives faster. They're the only nationwide MSK practice with doctor-led care teams and have a very advanced approach to whole person team-based care, which is going to be a big theme of our discussion today, that, in my opinion, this is my opinion, now I'm going off script, can be applied and reapplied to most chronic and complex conditions. I'll be telling you a little bit more about them later on during this episode, but if you want to check them out right now, go to vorihealth.com. All right, let's get started. I'm going to bring on Shelley Turk, who just arrived hot into on stage here. So Shelley, thanks for joining us. Shelley Turk is the Divisional Senior Vice President of Healthcare Delivery at Blue Cross and Blue Shield of Illinois. And I want to let's jump right into it, Shelley. How is Blue Cross Blue Shield of Illinois approaching obesity and the impact of other conditions like MSK, cardiometabolic, et cetera?
Yeah, we're in a really interesting time, right? Because it's the first time, I think, in recent history that I can remember kind of a condition like this getting the amount of attention that it is, and also thinking about it in new and different ways. It almost reminds me of the times of, when people used to talk about depression back in the 80s, they'd say, just smile more, right? Or alcoholism, you can just not drink. And with obesity, it's similar. It's like, just have willpower, just eat less and move more. It's really easy. And what we're realizing is that obesity is not only a chronic condition, but it's also a complex condition. And I guess I would start with kind of current state, what I see, which is the management of obesity as a chronic condition is fragmented, right? So you have management and referrals by the primary care physician, but there's kind of a lack of incentive for that primary care physician to really have a discussion with patients or ensure proper documentation that this person actually has obesity. And part of that is because traditionally providers haven't been compensated for obesity. So why would it be coded for? If you diagnose it, you have to treat it. We obviously know that there's no silver bullet to treat diabetes. Not diabetes. Diabetes and obesity go together, but obesity. And part of the reason for that, I think, when we're kind of thinking about history, sort of what the long-term effects are, we really don't know how to fix obesity. But when you think about current state, it's those PCPs. Only 9% of physicians are trained in obesity medicine, so there's a barrier. PCPs don't know how to talk about it with their patients necessarily, and they aren't necessarily incentivized to do it. And then there's lifestyle and coaching. Coaching's available to some, but not all, with members, and there's a lack of coordination with the PCP sometimes and a treatment plan. And when we think about the pharmacy space, medications specifically for weight loss are often only covered for some of our, limited ASO groups, or have extensive PA requirements, those sorts of things, or are approved for, and when I say extensive PA requirements, that's really around weight loss. For diabetes, obviously type 2 diabetes in particular, GLP-1s are being prescribed and covered and that sort of thing. And we're in this space where there's this tension between, the cost plus effectiveness, and really evaluating like, what does this look like long term? And then thinking about bariatric surgery too. That's the other piece of it, right? There's extremely limited utilization of bariatric surgery. It generally requires a BMI of 40 plus or a BMI of 35 with kind of one or more comorbidities. And so that's like current state where most payers, I think, are in some form or fashion. And what we want to move to is really thinking about the future state, a holistic way of looking at patients, using data and analytics to kind of get into a primary care model where diagnosis, documentation, and treatment is happening, thinking about vended weight management solutions that might be helpful to kind of aid the PCP and the member, thinking about different product incentives, health insurance product incentives for members to stay engaged in their journey, thinking about case management and care management for weight regain so that we can get to patients once they're on their journey, have lost a fair amount of weight, either through lifestyle, medication, mental health treatment, bariatric surgery, kind of thinking about all those different pieces, and then moving them forward into longitudinal programs that will help members to manage their weight long-term over time. So those are the things that we're looking at. And it's really thinking more about a whole person approach, not just treating only high blood pressure or only sleep apnea.
Right.
We have to kind of look at this from a bit of a different perspective. And those are the kinds of conversations we're having right now.
Perfect. You set the stage, and you set the stage for a couple of different dialogues that I want to go into. I'm going to not take the bait on and benefit design just yet. I'm going to take the bait on whole person care, that full spectrum stuff, and bring in Dr. Mary O'Connor. She is the Chief Medical Officer, an orthopedic surgeon, and co-founder of an organization called Vori Health. So, Mary, why is I'm going to go right into orthopedics and MSK. Why is full spectrum care so challenging, and how does an orthopedic surgeon and CMO look at building a whole person care program that focuses on MSK, but obviously has comorbidities tied to mental health and, of course, obesity?
Yeah, Eric, that is a great question. And full spectrum care in orthopedics is really so hard because orthopedic surgeons, and as you said, I'm an orthopedic surgeon, and spine surgeons, we focus on surgery. And surgeons should focus on that. They're very highly skilled and trained. And the reality is the lesser known fact is that surgeons right now are not well trained in non-surgical care. And the health system is biased as a general statement towards surgical care because surgery drives financial margins. So these factors make it hard, really hard, for a more full spectrum care model to be adopted in the traditional orthopedic setting. But we can solve that. We can achieve full spectrum care with the right care team. And the right person to lead that team is not a surgeon, and I'm saying that as a surgeon, but a physician who's well-trained in MSK, understands like the multifactorial nature of pain and the impact of comorbidities on MSK conditions, particularly obesity. So this initial physician is going to focus on getting the patient better without an operation and refers patients to surgeons when appropriate. And I often say that Ryan Grant, who's my co-founder, our CEO, and a spine neurosurgeon, and we're surgeons, and we're not anti-surgery. We're just anti-inappropriate surgery, which is why we founded Vori Health. So I know that this non-operative MSK physician first model works. When I was chair of orthopedic surgery at Mayo Clinic in Florida, I incorporated this model into our previous all surgeon department. And the impetus for this change was really about access. How could I make sure that we were providing good, timely access for patients? And this model, this change in the model of bringing non-surgeon MSK physicians in worked amazingly well. The surgeons were able to spend more time at operating at the top of their skill set. The patients were very satisfied, and it was just a beautiful thing. So how do you build this type of model? Well, what I learned at Mayo, and then subsequently when I was leading an MSK group at Yale, is that for a whole person care program to be successful, there are some critical elements. First, non-operative MSK physician at the helm who can provide a medical diagnosis, order tests and medications as appropriate. Number two, of course, we need physical therapists because PT is a bedrock of MSK treatment. Three, health coaches. Why? Because we can no longer ignore the importance of addressing behavior change, which is so often essential in MSK if we're going to achieve longer-term solutions. And we'll touch on this with the application of GLPs, and then registered dietitians for patients who need more advanced nutritional support. And then finally, a referral network for excellent surgeons. So those are the critical elements for this full spectrum care. We've built that in the virtual model, and I'm happy to say that we're really making a difference. So we had the Validation Institute look at our experience with low back pain patients. And less than 3% of our low back pain patients we refer to surgery, which is a 78% reduction compared to traditional care. And I want to take a moment to emphasize how important this is for patients. It's not just about saving costs, because we know from multiple studies that up to 50% of low back surgeries are inappropriate. Wow, right? But it's not just that these inappropriate surgeries stress payers. It creates financial hardship for patients and their families, and it puts patients at unnecessary risk of postoperative complications. And when we recognize this shocking statistic that 5 to 7% of patients who've had low back surgery are back in the OR within the first year after that surgery, we understand that there is a human price that is paid for inappropriate surgeries as well. So those are all the reasons why, creating this full spectrum care is so important.
Yeah, I love that. I want to see if I caught this correctly, and I'm going to summarize what you said as far as building the program up. You want a non-surgeon as the quarterback. My words, not yours. Just keep me honest here, Mary. 2, you want a physical therapist on the team. You want a health coach on the team. So we've got 3 members. 4th member would be a registered dietitian. So you have a 4-person team, and then you need to have a connection to really good network of surgeons for appropriate referrals as sort of the 5th piece. Did I caught that? Where does mental health come into that?
So mental health comes into that with our health coaches addressing a lot of, I'll call lower level depression, anxiety. So we screen all our patients for mental health. And if somebody is screening on, I'll call a more significant level, then we're reaching out to engage their PCP or directly referring them to another mental health provider. So depression is so commonplace in patients with chronic MSK conditions. We can't ignore that any more than we can ignore the impact of obesity.
Okay, so I'm going to add maybe the 6th piece, and that would be sort of making sure there's two-way communication with the PCP and also having access to a network of mental health therapists and providers is my guess, beyond the coaches for the higher acuity.
Correct, absolutely. And we partner with virtual mental health solutions if that's an option for the patient as well.
That's great. Let me move over to the great state of Texas, where Evry Health, which is a smaller but really innovative health plan, is, and introduce you to their chief medical officer, Dr. Mamata Majmundar. I hope I got that right. I mean, I've only had dinner with you and talked to you a million times. I still can't pronounce your last name. Sorry. So, Mamata, how are you designing your full spectrum care program? You're small, you're more nimble, so you can get much more flexible than maybe some of the larger plans listening. And how do you do that to support your highest cost members?
Yeah. Thank you for the introduction, Eric. One of the things, I'm a primary care physician by trade, so it's very interesting listening to the different conversations. For us, and for me, when I'm building, we're thinking about patient-centered care, really whole person care, where you're taking into account, as Mary and Shelley had said, physical, mental health, behavioral outcomes, respecting members for where they are. I think the three keys that I see is communication, coordination of care, and collaboration. And with that main point guard or quarterback, most patients do not have a primary care physician, and that's where it gets a little dicey. So when we're building our full spectrum care programs, we have to take a really individualized approach. What does the member actually have and need in place? And some solutions don't have everything we need. So it might be pinpointing them to a primary care doctor or getting them to a physician that is open to look at ideas outside of full spectrum surgery, as Mary was saying. Some things resonate with some members, others don't. So let's say, for example, we have a member that has an MSK issue and they also have diabetes. We want to make sure, number one, do they really need surgery or not? We get our care coordinators together to work with the patient as well as the physician. That's the key, working together as a group to coordinate their care to see what they need. And a lot of times it may be mental health. And I loved how you brought that up, Eric, because in my mind, there's 4 keys with any sort of comorbidity. Physical exercise, you have mental health, as well as nutritionists, and then the physician. Those together, working with ancillary providers to help coordinate the care. So we have had cases, which has been really enlightening, where a physician might not know that a particular member is struggling with a certain issue. And if the patient gives us that ability to communicate with them, then we work with that doctor and we let the doctor know that we have solutions for mental health. So if the physician deems that this person isn't a candidate for surgery, and maybe what they need first is better control of their diabetes, maybe weight loss reduction, or even mental health solutions, we can provide that and work with the doctor. And that, I think, is really the key, is making sure that we find a personalized solution with good partners.
Love that. And so I think we have sort of the baseline, a continued theme from what Mary was saying: coordination, communication, collaboration, and making sure they have a PCP, and making sure that you figure out a way or a process to individualize your program for each individual member. You mentioned physician, mental health, nutrition. I want to spend the next 20 minutes or so talking about GLP-1s and medication management. I also want to bring in the conversation around value-based care, because I think it's going to be important to solving this problem and getting your perspectives on all of that. So that's what we're going to focus on a little bit for the next 15, 20 minutes for those of you listening. I want to bring in Marty Burruano. He's the Vice President of Pharmacy Services at Independent Health in Western New York. Shout out to the 716 folks listening. So Marty, how are you guys up there? And if you don't know about Independent Health, they're a perennial 5-star MA plan. how are you creating systems to prevent the inappropriate use and prescribing of GLP-1s?
Listening to this great discussion, I see synergies already in not just preventing off-label use, but in encouraging appropriate use. And we take, and Mamata mentioned just now that we actually take a centered care approach around the PCP as well. And the PCP is the quarterback of the patient's care. We support PCPs. We have value-based reimbursement for PCPs to encourage them to be the quarterback of that patient's care. And Shelley actually articulated as well that with weight management, obesity, GLP use, it needs to be a holistic approach. Again, the PCP, and being able to direct care appropriately. So we look at that as in developing our criteria for off-label use, prevention, and also for appropriate use, to look at this and manage it for the long haul that way, and provide the PCP with the tools for things like lifestyle weight management, evidence-based programs to recommend and support for the care of their patients. So we developed a robust prior authorization and utilization management criteria to encourage that, and to build that infrastructure, and also looking at it from a holistic approach, also with behavioral health components as well. Lifestyle management, weight loss management is not easy. It's very difficult. So that's basically how our policy is driven, and then we use that prior authorization edit to bring those patients in so that we can manage them that way. And then as far as preventing off-label use, we own and operate our own PBM. So we have some flexibility there where we can utilize our medical claims data, in this case specifically, a disease registry for type 2 diabetes. We've incorporated that into our pharmacy claims adjudication system. So if a member or patient doesn't have a diagnosis of diabetes, the claim is rejected or blocked at the point of sale at the pharmacy, because they're not diabetic. So it's not just the weight loss GLPs; those require prior auth, but the GLPs that are approved for weight loss or approved for diabetes are blocked at the point of sale if there's no diabetes diagnosis, because we want them to, if they need a weight loss medication, we want to be able to incorporate that into the prior authorization process so we can help manage it. Another feature within our prior authorization criteria is we actually restrict the prescribing of this to PCPs and require in-person assessments by the PCP in order to be as one of the criteria for prescribing a GLP-1. And we found that to be very effective in preventing, I don't know if it's the right term, but indiscriminate use with GLPs through prescribers that are not following this patient. It's not really their patient. They're not following this patient and working with them in a holistic approach like their PCP would. So really, in essence, we're restricting it to PCPs.
Okay, fascinating. And I know there's going to be different ways and different approaches that different plans go about doing this. It strikes me, before I bring back in Shelley, that one of the articles that I read in preparation for this episode was entitled "Integrating GLP-1s into the Future of MSK Care." It was a physician-authored piece. It is by the clinical leadership at Vori, but a really good overview and a lot of good thought-provoking insights into how we should be thinking about our strategy, especially as it relates to musculoskeletal and pain and obesity. So if you want a copy of that, it's an easy read, or I would have read it. It's an easy read, but it's very informative. And if you want a copy of that, we're going to put up a poll. Sherry will put up a poll, and we could just send it to you, so you don't have to go through any gates or try to find it online and have to type in your information. We'll just send it right out to you. So if you want a piece of that, we'll put that up. Shelley Turk, as Mamata Divisional Senior Vice President, Healthcare Delivery, Blue Cross Blue Shield, Illinois. How are you guys, Shelley, thinking about value, and how are you thinking about your provider partnerships when you're thinking about MSK and you're tackling obesity? As everyone just said, we don't have a lot of physicians who are experts in weight loss. So how are you guys approaching it?
Ideally, we would manage MSK, diabetes, heart disease, non-alcoholic fatty liver disease, high blood pressure with obesity, all of those things together, right? Because you can't look at any of these things in a vacuum. And so as we're exploring what the future of obesity healthcare treatment and management might look like, an end-to-end obesity program has to include a combination of value-based care models to manage targeted treatment stages, and it has to align with the insurer's coverage policies, right? Because if we don't have, let's say, a particular, I'll just, make it up. There's an employer group. Let's say they've decided not to cover bariatric surgery or any drugs, and not just GLP-1s. I mean, I think what's been lost in this conversation around GLP-1s is that there are actually multiple weight loss medications that are available that are older, have historically been used. I mean, there's HCl bupropion, there's phentermine, there's Contrave, there's Belviq, lots of different drugs that are available. And so if the employer group, for instance, doesn't cover any of those things, it's hard to say to a physician, I want you to manage obesity, but I'm not going to give you all of the tools to be able to do that. And so, but that doesn't mean that you just say, okay, everyone gets a GLP-1. Maybe it's step therapy. Maybe someone needs a weight loss drug to they've got over 100 pounds to lose. Maybe they have over 200 pounds to lose. They need to get on some type of appetite suppressant early on to be able to jumpstart their efforts. There's this conversation about, do you require people to have some type of lifestyle change before you give them a drug? And I don't know that we've come to an agreement on that, but I would argue that in some circumstances, people actually need an appetite suppressant to be able to lose a little bit of weight. They lose 10 pounds, then they actually feel like exercising a bit more. They start exercising, their anxiety decreases, their depression decreases. Now they're able to eat a little bit better. And so, these things all to go together. And I would say bariatric surgery is kind of the same from, maybe an employer group plan perspective. If there isn't coverage for bariatric surgery, it's, obviously difficult to get people into that kind of program. But the value-based care continuum and the complexity kind of starts small, right? So you would want to incentivize patient engagement, have some type of diagnosis incentive that's more of like a P for P, where documenting the member biometric data, their weight, their BMI, their waist circumference, all of that gives data that makes that data available so that there can be additional assessment of these patients. So that's like the starting point, right? I also believe there's something meaningful about actually measuring a patient's arms and measuring a patient's waist and measuring, maybe their legs as well. And really kind of getting into that space with the patient where you're actually starting to have this conversation. There's something meaningful about that in addition to the data piece. And then you can move on to a referral or treatment plan type of incentive where referral to a wellness or obesity program or an integrated medicine program that manages all of their conditions plus the obesity and develops a treatment plan for them. That's kind of like, phase 2 of a stage 1 kind of value-based care program. Moving into like the next stage, which I'll call stage 2, now you're getting into like reducing complications and costs for surgical treatment, right? So you're thinking about a quality incentive payment or a surgical pay for performance payment. So you're saying to bariatric surgeons, if you improve quality or efficient treatment options, we're going to incentivize you for that. Or maybe you do a bundled surgical model where you have one comprehensive payment for bariatric surgery with quality measures. And maybe there's, even a piece of that where the bundle covers complications that might result from the bariatric surgery. Although, bariatric surgery has become so much safer than it was ago, and a lot of it's being done laparoscopically now. There just have been huge advancements. That kind of stage 2 value-based care program is it's only helpful if the uptake on bariatric surgery is higher, which goes back to aligning with those coverage options, right? If the coverage is available, now do we have incentives, from a product standpoint and health insurance product standpoint for those members? And if more members are going into that space, now you've got the provider incentives for the surgical models. That all goes together. If the uptake on surgery is very, very low, that kind of value-based care program won't be as helpful. And then finally, the third stage is managing obesity holistically. So thinking about obesity measures within an accountable care organization program. You look at the obesity total medical cost of care, or that member's total cost of care across provider groups. You have separate benchmarks. You think about different types of ACOs based on their particular population. And you might even look at MSK measures in addition to obesity measures to try to tie the conditions together with the obesity, and thinking about targeted metrics that are actually designed for members with obesity, as well as their specific comorbidities, and including that maybe as an additional layer into the model. And then, as I mentioned before, there are all of these vended options, right? So there's obesity management, where you can kind of take a targeted population, and some of these vended solutions are actually taking risk, which is pretty interesting. And they're taking risk on improvement in outcomes. And then you have to kind of decide too, what is the outcome that we want? This isn't a play, to sort of have everyone be as thin as possible. Do you say, okay, if someone loses 10% of their body weight or 20% of their body weight, that's success. And the loss of that body weight then is also contributing to patients not needing to take as much medication, or not having as many joint issues, or not needing to, maybe they were pre-diabetic and now they are no longer pre-diabetic. So I think individual solutions can be implemented as programs evolve, but these are the kinds of things that I think we need to be looking at for value-based care.
So that's a perfect, I want to jump in and maybe Mary, how does that Mayo model that you described earlier, how could that be integrated into a value-based care arrangement and support taking on risk, like was just outlined for us by Shelley? Maybe even provide us an example.
Love to, Eric. So I think that, fundamentally, the core elements for that value-based model is you've got to have the right care team. And particularly for MSK, the big gap that I've already mentioned is that a lot of PCPs, God bless them, I love them, have an education gap with MSK, which is why they so commonly refer to ortho surgeons or spine surgeons. So you need the right care team led by non-surgeon, but MSK expert doc. The model needs to be patient-centered and holistic, like we've talked about, and easy access for patients. So I'll just share an example of a value-based partnership that we've entered into, and that's with Select Health. So we care for their Medicare Advantage members in Utah, Idaho, and Nevada. And our partnership allows those select seniors to receive basically end-to-end MSK care through our platform. So that can be on their laptop or desktop or phone. And we have been very encouraged, as has Select Health, with what we're seeing. And of course, this is a senior population, and they love the convenience of this. So what are we seeing? Higher utilization, greater than 10% of the members, Select Health, Medicare Advantage with MSK conditions, are utilizing our services, which is several percentage points higher than the industry standard. great clinical outcomes. 80% of the patients are improving in their pain and physical health function at 45 days. So we see rapid improvement. At 45 days, we have not referred any patient, it sounds a little crazy, but we've not referred them to the surgeon. We have referred about 3% for imaging and injections. And our net promoter score in this population is honestly, I'm not joking, an amazing 91. So I give a lot of credit to our clinical team and our platform. You know, it takes a village to create this experience for patients. And the other thing I'll point out is that the demographic data from our select population aligns with the MSK trends that we know, and that we see how intertwined MSK is with other comorbidities, especially obesity. So I don't want listeners to think that this is some kind of one-off. 74% of our select health patients that come to us with MSK are overweight or obese. Most of them come for back and knee pain. And this isn't surprising because we know that that extra weight really impacts the severity and progression of MSK conditions. You know, every 10 extra pounds is like another 30 to 60 extra pounds of weight on your knees. And 1 in 2 adults in the US has MSK pain, and 3 out of 4 are obese. So in order to drive a value-based partnership, again, that full spectrum care is really so important. And I'll leave it at that.
Okay, so I'm just going to, greater than 10% of the eligibles are using it. Outcomes are being seen within 45 days. No referrals to surgery yet, 3% to imaging. Is there anything about the characteristics of the value-based care risk-sharing arrangements that you want to share, or did we cover everything?
Well, one of the things that I think is so important in our partnership with Select Health is that all our services are covered. So we can give the patient the care that they need, whether with the health coach, pull in the registered dietitian if needed. And that is no cost to the patient because we have a bundled program with Select Health. And we love that concept, right? Let's bundle a program so that we can give patients what they need to help them get better and try to get better without an operation if possible. And so that just makes it so much easier on our clinical team and also on the patients.
That's great. I want to get back, thank you for that, Mary. I want to get back to medication management. Before we do, just for those of you who joined us a little bit late, Vori Health, if you haven't heard of them, you probably got the context from just listening to Dr. O'Connor, especially medical practice, virtual first MSK, only nationwide MSK practice with doctor care teams, doctor-led care teams. Really convenient for back, neck, and joint pain without forcing members to bounce around the healthcare system. So that's important. And whether they need a diagnosis, a non-opioid prescription, or personalized PT, or coaching, right? Coaching, which includes the mental health part of it, members are able to use the Vori Health whole person care team who are using evidence-based practices for that end-to-end support they need. And you heard the results just there, up to 4-to-1 ROI. And again, if you want more information on them, VoriHealth.com. I always send folks, if you are regulars, you know this, a feedback form. Our regulars probably know from just following the show that we take all that feedback and incorporate it into our programming and how we do things. So I'm hoping that in 6 minutes, when you get another email from me, that you'll take 2 or 3 minutes from your day to provide us multiple choice feedback to the questions we ask. One of them will be if you want to meet Dr. O'Connor and her team to just learn a little bit more about full spectrum care and what they do. It doesn't have to be a sales pitch, just information that you could tap into. And I'm happy to make that personal introduction. I won't just like throw your name over to them. I'll actually make an email introduction for you guys. So that'll be coming in about 5-6 minutes into your inbox. Back to medication management and our token Buffalo Bills fan, Marty. So one of the challenges we haven't addressed so far is the cost of not taking medication, right? So there's a cost there, even when it's those expensive GLP-1s. So, I know I mentioned earlier, independent health, perennial 5-star MA plan. You and your colleagues have been great guests on the show for the many years. You can't achieve that kind of greatness, that kind of excellence without best-in-class, MTM, best-in-class medication management program. So can you tell us a little bit about your program and why it's so successful, and maybe tie it into GLP-1 adherence and all that?
Sure. We do have a dedicated medication therapy management team of highly trained pharmacists, and we do extensive training with them on motivational interviewing, all kinds of things. And we also work with our local school of pharmacies, and we have 2 right in the Buffalo area, where we've actually worked with their didactic programs at the school for their students that we take on as preceptors. So they're kind of MTM ready when they come to us, and they know the program. They're ready to take on those roles. So that's helpful as well. So that's kind of a tool in our toolbox that everybody might not have access to, but it does work for us. And we've been able to achieve those 5 stars for several years, and be and high quality scores in HEDIS and in our Medicaid population, our CAR ratings as well. And we've done this through those pharmacists. They have trusted relationships with our members, because they repeat with them basically on an annual basis. We make sure they follow their same patients, year after year, on diabetes, drug adherence, for example, which is what we're talking about here. But then also be very persistent in looking at the patient from a 360 point of view, like we've been talking about in other areas. It's very important here too. And it's very important for them to kind of probe what other gaps do these patients have, what services are they not lacking, why aren't they taking the medication, what's the reason. And then we refer these patients either internally to care management. We have a Care for You program at Independent Health that works with high risk members, and those pharmacists refer patients to our MTM team as well, or those nurses, those nurse practitioners and physicians. It's a Care for You PC group that we operate, and so there's a lot of different tentacles where these patients can get referred to services, but the persistence comes in that we follow that up as well. We make sure our MTM team makes sure they're following those services, make sure they're taking those medications. Once they've had sometimes several conversations, and also persistence comes in with their providers as well. We're making several recommendations to providers to help influence adherence, or if they're not adherent, or if it's a drug discontinuation or a drug misadventure, whatever. They're working with the PCP, but sometimes it takes several attempts with the physician's office to effectuate that change. So they're very persistent in doing that, and really the end in mind in a lot of this is to identify any kind of SDOH potential issues, and get them the right care they need as a result of that. And obesity is one of them as well, in getting them into services or programs. We also have digital tools. One's called Brook, that members have access to free of charge for their diabetes care. Also has weight management programs within it too, and also has a pre-diabetes component. So we try to connect them to all those available resources, whether internal or external.
Okay, so I'm going to summarize that quickly, because you said a lot. In-house pharmacist is a key, and incentives with your providers, your IPAs, are key. But the overall, and you mentioned it a number of times, is making sure that you have a culture where your providers, in this case pharmacists, are persistent. Nothing in the world could take the place of persistence, right? Calvin Coolidge kind of quote, if you guys don't know it. And so looking at the patients, the whole picture, and being persistent in all the follow-up, identifying the different issues, whether it be clinical or social, and then also looking at the different claims data to guide them on when the follow-up should happen, identifying non-adherence and trying to inspire them to change that behavior. Did I capture, did I miss anything? And then, of course,
Very well.
lifestyle. Got
You
it.
paid
And
attention.
then, yeah,
you.
and it's digital tools. I try. So let's stay with member adherence and patient adherence and dip a little bit into sort of habit forming and lifestyle modification. And I'd love to hear, Mamata, why don't you talk a little bit about what, is a bright spot or a successful program you're building into your benefits to drive member behavior in a very productive way?
There's two main things that we're doing. Again, one is our personalized approach. And I want to bring up, we had a member that needed a unique solution. And again, not everyone wants to have a particular coach or a remote monitoring device or have to go in to have inpatient visits. So you have to be willing to listen and then explore what ideas you have available. And in this example, we were able to find a personalized solution where she was able to learn about her nutritional needs. And she improved her physical activity. She was able to reach her weight goal. And with that, we also created a reward incentive program. And for us, we all know that there's no quick fix. And we can all get very engaged and motivated. We start something, we're doing it for 30 days, 90 days. Think about it, we're in January. And how many people have met their goal or have dropped off with what they're doing? And one way we try to incentivize people to motivate that behavior change is through our incentive program. Everyone has an opportunity to earn rewards. They may be engaging in programs, metric-based. We really look at the individual person to help guide them. Again, our goal is to create habits and give people the tools and resources so that what success they have gained, that they can continue to sustain those changes. And that's really important to us. So to me, it's always wonderful to hear someone learn something such as, I didn't realize the new sweet tea that I'm drinking with my daughter when we go after a basketball game, our treat is stopping at McDonald's to get a sweet tea, that the sweet tea has caused me to have diabetes. And now just changing my behavior to maybe an unsweet iced tea. There's no medication involved. It's just that education. I've empowered someone to make that change. And then they can teach that to their family. I think that's really important, is giving them the opportunity to figure out how it can work with their lifestyle.
Yeah, it's really smart. I want to go down a few tangents here. I won't, but that really smart, like that bottom-up approach. Let me ask you a follow-up from one of our audience members, because you mentioned, and it seems like Evry is really focusing on the individual and how important it is to look at the individual. We've traditionally looked at population health, right? And so I'm curious, and this guest, Nancy, has asked, why do we think obesity is an individual issue when it's a family community issue and requires a pop health solution? Or does it require a pop health solution? Is that where we're going wrong?
So I actually love that question, because it is more than just an individual issue. There are population and community issues involved, which relate to policy. Do we have walkable cities? Do we have access to fresh fruits and vegetables at a lower cost that's there? There are things that sometimes are outside of our control. And I think it's important, whether you're an individual or you're in a payer or a physician's office, to advocate for changes that you think are important. And population, you might be dealing with certain cultures. And in a particular culture, their diet in the morning may be rice or tortillas. That is a staple in their diet, and it's built into their culture. So it's working with them, embracing that population, talking to members in that organization that have been successful with change, and then trying to incorporate that, making that a bright spot, how we can clone that has worked in that particular niche. And that's why you have to look at your community. You know, we may be in the whole state of Texas, but each community has their own culture, their own characteristics and needs, and that's important. So I think it's a two-pronged approach. I love that this viewer has brought this up because it's true. It's two things. And I believe you need to work with your policy and your legislators to get more access to things that you believe your community needs.
Good stuff. I know we're getting tight on time, folks. We have a couple of really important topics to cover. First of all, also, not as important, but certainly very relevant. We have 2 upcoming episodes you're going to want to pre-register for, and we're going to have put our producer Sherry Keels to the test and allow you guys to pre-register right now. I think, right, Sherry? I'm hoping that's correct. So I'm reading it in my notes. We've got a February 15th episode coming up on meeting goals for chronic condition management with fewer resources. So right in line with today's topic. And then we have on the 22nd, for those of you who have a strong exchange product or are battling in the exchange, we have February 22nd, differentiating your product in healthcare in the healthcare insurance marketplace. Both of these 12 p.m. East Coast time, 9 a.m. on the West Coast, Thursdays live, drop into the podcast feed the next day. So if you want to be part of those, I don't know, Sherry, if we have a poll to pre-register them. If we don't, that's okay. Oh, we do. See, I thought I did. She's on it. So you can pre-register. Let's I want to get into some personalization here. I'm going to start, actually go out of order here. I'm going to start with Mary, and then I got another question for one of our panelists. So getting back to Select Health, and you, I don't care if you use Select Health or any other health plan you work with, Mary, can you share an individual story on how a program works, you know, sort of dovetailing off of what we just heard from Mamata, and maybe even talk a little bit about, because we haven't brought it up specifically, but it was a question that came up prior to the one of our guests today. What's the impact too of muscle loss on patients taking GLP-1? So maybe we could cover those 2 in one, and then maybe I'll turn it back to Sherry to close us out. Go ahead.
Eric, I'd love to, because, you know, patients are really the reason why we're all here. So I'll share a story of one of our Select Health patients, and I'll call her Annie. And Anne had severe low back pain. She came to us, 30 years of back pain, 8 out of 10 on most days, numerous epidural steroid injections in the past, which really didn't help her. She's diabetic, insulin dependent, she's obese, she's 315 pounds with a BMI of 45. So she is a classic patient that is just suffering, right? She's depressed. She can't seem to find help in the traditional system. So she started with our care team, our full spectrum care, and she's been with us now for 3 months. So her doctor diagnosis is degenerative disc disease and some spinal stenosis. Probably this audience understand that means some arthritis, pinching the nerves in her back. So she gets started on her virtual physical therapy, her virtual health coaching, registered dietitian to help with nutrition. So 3 months, her pain is now averaging 4 out of 10. She understands the importance, because we also work with patients on pain education, so they understand how they can better manage their pain. She's lost 33 pounds. Her BMI is down to 41 now. She stopped taking her insulin. She's able to eat and manage her meals better to help control her blood sugar. She's not getting epidural injections anymore. She's not as depressed. I mean, she still has some off days, but she's just dramatically better. She and her husband are going to move to a warmer state, and she's just thrilled. Now, I want to make one other comment that's particularly important for older patients, and particularly for female patients, which is some of the side effects of the GLP-1 ones, which is not always well appreciated, is bone loss and loss of lean muscle mass.
Right.
This is particularly important. And I know my bias as an orthopedic surgeon, because I've treated hundreds and hundreds of patients with fractures, with fragility fractures and hip fractures. And this is devastating to not only the patient, but their family. And I know this, my 94-year-old mother last year broke her hip. Okay. So so if we're going to put all these patients on these new medications, and we're not going to be proactively mitigating the impact on bone strength and lean muscle mass, because as you lose muscle mass, your risk of falling increases, which then increases your risk of fracture, then we are harming patients and we are just creating more healthcare costs. So again, when we approach this in our care model, we are looking at these issues as well to make sure that, does the patient need a DEXA to assess their bone health? Are they on medication if appropriate? So that really more holistic care. How are we working with them to mitigate the loss of lean muscle mass? So again, GLP-1s, amazing medications. Let's not take away the incredible research advance this is, but we also have to really understand, how are we going to use this medication best in a holistic model that will really drive value for patients and the healthcare system as a whole.
Great stuff. Great stuff. So I want to stay on the individual side of things, and so that we're really thinking empathetically when we talk about the strategy of creating programs that are going to work for the population and the individual. So Shelley, Turk is a senior leader at the country's largest customer-owned health insurer. Why, Shelley, are you so passionate about this, and does it go beyond the business value of getting this right?
Yeah, it does. I mean, we've absolutely started the journey at Blue Cross. For GLP-1s, we're continuing to focus on ensuring coverage and minimizing barriers for patients with type 2 diabetes, while also supporting weight loss coverage as a custom benefit option for our employer groups. We have things like Weight Watchers, Noom, fitness center memberships through Blue 365, Wonder Health, Mamata. There are other things. So we're absolutely on this journey. And the work that I'm doing right now is to kind of keep pushing us into the future state and where we want to be. And a big part of that is because I've lost over 100 pounds twice in my life, not once, but twice. I'm a sort of a obesity journey case study, but I've been on probably most of the different weight loss medications that have been available, with the exception of GLP-1s. My decision eventually, after a lot of sort of treatment and soul searching, was to have bariatric surgery, gastric bypass in 2021. For me personally, that has been a very successful treatment modality, but it's also in combination with all of the different pieces that we've been discussing. And for me personally, one of the things that I had to figure out is, why was I eating more than my body required for life? And that often involves a deep dive into everything from lifestyle choices, habits, mental health, thinking about stress, anxiety, depression, all of those kinds of things. It all goes into that bucket. And it's interesting, we're seeing in our claims data at Blue Cross that generalized anxiety and anxiety are tight correlators to obesity. And if those comorbidities are present, really ensuring that we have that mental health component, cognitive behavioral therapy, I think will be really, really key. So the reason why I'm so passionate about this topic, and why I could talk about it all day long, I wish we had 3 hours, I feel like we've just scratched the surface, is because I've had this personal journey with obesity. And in large part, it's been a journey that has been predominantly, I would say, like, driven by me, right? And not just from a emotional standpoint and from a physical standpoint, but also from a financial standpoint. And so really thinking about, how do we look at obesity as a complex chronic condition and really treat it as such, and help people to have better outcomes for their whole life, their whole person, and all of the different conditions that they might have in addition to obesity.
This is why, folks, you need to stay to the end of the episode. That was wonderful. So thank you for sharing that. Really, thank you, Shelley. Thank you to everyone who takes the time for every episode to join us live or download the show wherever you may be when you're downloading it. We don't take the hour you spent with us lightly. We know you're busy, so we're hoping we earn your trust each and every episode. I want to thank the four of you, our four guests, for all the time and effort you took to prepare and participate today. Check out our friends at Vori Health, vorihealth.com. We hope all of you listening use the ideas, bright spots, thoughts to inspire your thinking and enhance your organization's current approach to improving healthcare for all of us. This is your Bright Spots in Healthcare podcast. Take care, everyone.
Thank you, Eric. Thank you, everyone.